everyone, and welcome to COPD and Medicare Made Simple, preparing for the annual enrollment period. I am Johnny Karinko, a respiratory therapist and educator here at the COPD Foundation. I will moderate today's discussion. Today, we are lucky to be joined by Emily Wichlow, the Director of Education for the Medicare Rights Center. She will guide us through Medicare options and coverage for common COPD treatments and give us tips for managing medication costs. As you have questions, please feel free to drop them into the chat or the Q&A feature, and we will answer them at the end of the webinar. So with that, I'm going to turn things over to Emily and we'll get started. Thank you, Emily.
Thank you, Johnny. Thank you to the COPD Foundation for having me here today. I have some slides that I will share. And as Johnny mentioned, if you have questions as I'm going through, please feel free to put them in the chat. We have a lot to get through today, so hopefully we'll be able to get to everything. As Johnny mentioned, I work at a nonprofit called the Medicare Rights Center. We are a national consumer service organization that helps people with disabilities and older adults access affordable healthcare. We do counseling and advocacy. We have a national helpline that people call with Medicare questions. We do educational programming, and we have a team in DC that works to strengthen and protect the Medicare program. So today we'll be talking about a couple of different things. The first to level set, we will talk about how and when to enroll in Medicare and Medicare basics in general. We'll then talk about how Medicare covers common treatments and medications for COPD. And then we'll talk about how to compare your Medicare coverage options during the fall open enrollment period that begins on the 15th, so next Tuesday. So by way of introduction, I think it's important to look at some of the vocabulary that we'll be using during this presentation. The first important word to know, and many of you may already know these, but is premium. That is the monthly amount that someone pays to have their Medicare plan, private health plan, a Part D plan. This might be taken out of your Social Security benefits. You might be billed monthly for it. There are different ways you pay your premium. The deductible is the costs that you have to pay usually at the beginning of the year before Medicare or your other insurance begins to cover the cost of your services. So Medicare this year has a $240 deductible for outpatient care. The first time you go to the doctor in the new year, you probably owe that amount. After that, you start to have the coinsurance that Medicare charges. A coinsurance is a portion of the cost that you pay after your health insurance pays. So with original Medicare, which we'll be talking about in a moment, you usually owe 20% of the cost of a service. This is in contrast to a copay, which is a set amount that someone pays for each medical service they receive. And if you've had other private insurance before Medicare, you're probably familiar with copays, like $25 to go to the doctor, maybe $50 for a specialist. It's a set amount, slightly more predictable. Two other important terms. The first is prior authorization, and this is the requirement that a plan has that you get approval from the plan before it covers a service. And we'll talk about this in more detail later in the presentation, but it can be a barrier to accessing care sometimes. And then lastly is formulary. And this is the list of drugs that a plan covers. We'll be talking a bit about how important it is to find plans that have your drugs on their formulary, on their list of drugs that they will cover. So for those of you who aren't as familiar with the Medicare program, by way of background, it is the federal health insurance program that provides healthcare coverage for people who are 65 and older. That's the main population we think of as having Medicare. But it's also available to people who are under 65 and have been receiving Social Security Disability Insurance, SSDI, for a certain amount of time. This is usually 24 months. During that 25th month, you become eligible for Medicare if you're under 65 and you've been collecting Social Security Disability for 2 years. Other people who are under 65 can qualify if they have end-stage renal disease, ESRD, which is kidney failure requiring dialysis or transplant. So the main Medicare population is people who are 65 and older, but about 10–11% of people have Medicare due to disability or end-stage renal disease. Oops. So there are two ways to enroll in Medicare. The first is sort of passive, if you're automatically enrolled. You're automatically enrolled if you're already collecting Social Security benefits before you turn 65. So you can start collecting your Social Security retirement at 62. Some people take it then, and when they turn 65, they automatically get Medicare. Or if you have a disability and you've been receiving it for at least 24 months, SSDI for at least 24 months, you're automatically enrolled in that 25th month. Or if you are getting SSDI because you have amyotrophic lateral sclerosis or ALS, you're automatically enrolled in Medicare the first month that you receive SSDI benefits for having ALS. So essentially, if you're already in Social Security system and receiving benefits from them when you become eligible for Medicare, you'll be automatically enrolled. But if you're not automatically enrolled, and this is becoming more common as people delay their retirement age past age 65, you have to actively sign up. So the first time to sign up is during your initial enrollment period. This is the 3 months before, the month of, and 3 months after your 65th birthday month. And unless you're working and have coverage from work, or your spouse is working and you have coverage from their job, it's best to enroll actively in Medicare at age 65 to avoid delays in coverage and late enrollment penalties. And if you're turning 65, you want to start thinking about Medicare enrollment the 3 months before. You can sign up. If your birthday is in April, you can sign up starting in January, and your Medicare coverage will start April 1st. If you enroll in your birthday month, so if you were, 65 in April, you could enroll in April, May, June, or July, and your coverage begins the 1st of the next month if you enroll when you turn 65 or any of the 3 months after. And there's no late enrollment penalty for enrolling during your initial enrollment period, but we do recommend enrolling before you turn 65 so that Medicare starts as soon as possible. The alternative enrollment path is a special enrollment period, and the most common one that people use is the SEP, or special enrollment period, for those who are currently working. If you have coverage from work, or your spouse does, and it covers you as well, you can delay Medicare without penalty until you are ready to retire, or your spouse is ready to retire and they lose coverage. The last time to enroll in Medicare for the first time is the general enrollment period. And this is, you generally want to try and avoid enrolling during the GEP because, one, you'll usually have a late enrollment penalty, and two, it only runs January 1st to March 31st of each year. So if you delayed Medicare enrollment and now it's July, let's say you need Medicare, if you don't qualify for a special enrollment period, you'd have to wait until January of the next year to get coverage. And so take away from this slide, if you're turning 65 and you don't have coverage from your or your spouse's current work, it's best to enroll in Medicare 3 months before, in the 3 months leading up to your 65th birthday. Once you are enrolled in Medicare, you have a choice of 2 different ways to receive your Medicare benefits. There's Original Medicare, which is the traditional program administered by the federal government. You get your red, white, and blue card in the mail. You show that to your doctors. And then there are Medicare Advantage plans, which are private insurance companies that provide all of your Medicare benefits through one plan. It's not a separate benefit. It's just a different way for your benefits to be administered. And if you already have Medicare or you're approaching Medicare eligibility age, I'm sure you've seen a lot of ads for these plans. They market a lot and are offered by a lot of the common health insurance companies like United Healthcare, Humana, Cigna, WellCare, companies like that. So Medicare benefits are administered kind of in 3 parts. We have Part A, which is the hospital or inpatient benefit, Part B, the doctor or outpatient benefit, and then Part D, the prescription drug benefit. And we'll talk about how these parts are administered differently depending on whether you choose Original Medicare or Medicare Advantage plan. Original Medicare includes the A and the B, whereas Medicare Advantage plans include everything together. So in this section, I just wanted to go over some of the differences between the types of Medicare coverage you might encounter, because it can help you decide which option is best for you. So the first thing that's really important with Medicare is to make sure that you see the right type of provider. This will ensure that you are able to pay the least for your healthcare services and items. So with Original Medicare, you want to see a provider who accepts Medicare and takes assignment. This phrase, takes assignment, is a little bit technical, but basically it means that they accept Medicare's payment as payment in full. So if Medicare says this service costs $100, the provider says, okay, I accept $100. Medicare pays me $80, 80%. You pay me $20 or 20%, and we leave it at that. If a provider does not take assignment, you may owe a higher cost because they can charge you a little bit above that $100. They can charge up to 15% more. So then the 20% that you owe will be more than $20 because they can charge up to, in our example, 115. The best way to find providers that take Original Medicare, you can call 1-800-Medicare, you can ask your provider if they take assignment, and you can use the Medicare Care Compare tool on medicare.gov. With Medicare Advantage, the private plans that combine your A and B and D benefits, you'll want to see an in-network provider. Again, if you've had private insurance up until now and you're newly eligible for Medicare, you're probably familiar already with this concept of if you stay in network, you have the lower costs. If you go out of network, you're either paying 100% of the out-of-pocket cost or your plan's only providing a very small amount of coverage and you have a higher cost. So when thinking about what type of coverage is best for you, you should really make sure that your providers are either in network for Medicare Advantage, if that's what you choose, or accept Medicare and take assignment if you choose Original Medicare. So let's now look at Original Medicare versus Medicare Advantage at a high level. So as I mentioned, with this coverage, you can receive covered services with Original Medicare from any provider in the US who accepts Medicare. Whereas with Medicare Advantage, you have to see in-network providers in your service area to receive covered care at the lowest cost. With Original Medicare, there is no referral requirement for Medicare to cover specialists. So if you need to go see a cardiologist, you can go straight there without Medicare needing to know about it from your primary care physician or anything like that. But with Medicare Advantage, you may need a referral for a specialist, which means if you want to go see your cardiologist first, you have to have an appointment with your primary care doctor. They get you the referral, and then you can go see the specialist. With Original Medicare, there are some services that are not covered. Three main categories that people wish were covered by Original Medicare include hearing, vision, or dental care. Whereas Medicare Advantage plans have the flexibility to offer some supplemental benefits, including hearing, vision, or dental. And it's usually pretty basic coverage, like the 2 dental cleanings per year, or money towards a pair of eyeglasses, but it's not extremely comprehensive. With Original Medicare, there's no limit on out-of-pocket costs, and so some people opt to purchase a Medigap policy to cover Medicare cost sharing. And we'll talk about Medigaps in a moment. In contrast, Medicare Advantage plans must have a maximum out-of-pocket limit, or MOOP. The maximum out-of-pocket limit in 2024 is around a little over $8,000. Once you hit that cap, you owe nothing for covered services for the rest of the year. And $8,000 is very high, but for people who have a lot of healthcare costs, this does provide at least some level of kind of coverage beyond that $8,000. They'll know they have no more costs for the rest of the year. And just a quick comparison of the cost of the two programs. So everybody with Medicare owes the Part B premium, which is $174. If you have a Medicare Advantage plan, you owe the $174, and you may also pay an extra premium to that plan. The original Medicare has deductibles and co-insurances for care, whereas Medicare Advantage plans, it's hard to say across the board what they charge because each plan is different. So it may charge different deductibles, it may charge different co-payments from one plan to the next and between one plan compared to original Medicare. So especially during this open enrollment period, as you're receiving notices about your coverage, it's a good idea to take a look and see next year what your plan might be charging you for hospital stays, for skilled nursing facility stays, to see your primary care doctor, to see your specialist. As I mentioned on the last slide, people who choose original Medicare, they don't have an out-of-pocket limit. And so a lot of people, or many people, choose to purchase a supplemental policy called a Medigap. These are plans sold by private insurance companies that pay after Medicare for the leftover costs that Medicare doesn't cover. And out of the 10 standardized plans, there's a little bit of variation in what they cover, but all 10 plans must cover your daily costs when you are a hospital inpatient, the 20% Part B coinsurance or part of it, the cost of blood, and any hospice care coinsurances. The thing to keep in mind, though, is that these Medigap policies do charge a monthly premium, and these premiums depend on where you live and sometimes how old you are, but in general will probably be somewhere between $100 to $300 more per month. And so when thinking about whether or not to get a Medigap, it's important to kind of compare that to what you think your out-of-pocket costs would be otherwise and see if it would save you money. The other kind of tricky thing about Medigaps is that in most states, insurance companies must sell a policy only at certain times if you meet certain requirements. And so Medigaps may not be available to everybody. There are federal rules that I'll talk about, but your state may have additional flexibilities. So under federal law, you only have the right to purchase a Medigap policy if you're 65 or older, and you buy your policy during a protected enrollment period. And there are a couple of protected enrollment periods. The first is when you first turn 65 and you enroll in Part B. You have 6 months to purchase a Medigap. And then there are other protected times called guaranteed issue rights, like if you lose retiree coverage or you signed up for a Medicare Advantage plan when you first became eligible for Medicare, and now you want to switch back to original Medicare within that first year. There are certain times where you can purchase a Medigap. During these protected times, it's important, or the reason why these protected times are important is because during them, an insurance company cannot deny you coverage or charge you more because of past or present health problems. You might have heard of medical underwriting. If you are past age 65 and you've already enrolled in Part B, it's been a couple of years since you got Medicare, and you want to go and purchase a Medigap, the Medigap policy might say, ooh, we're going to charge you more because of your age, or we're going to make you wait before we cover your pre-existing conditions, or they can even say, we're not going to cover you at all. And so it's important to, if you do want a Medigap, to either sign up when you're first eligible at age 65 and enrolled in Part B, or to contact your state health insurance assistance program to learn if there are any state-specific enrollment rules that may be able to help you. And to find your SHIP, I'm just going to put the link to their website in the chat. If you go to shiphelp.org, you can find the phone number for your state health insurance assistance program. They're a great local resource for learning about Medigap policies and a lot of other Medicare coverage questions. So if you are considering original Medicare with a Medigap, one question that you'll want to think about is how does how do your monthly out-of-pocket costs or anticipated out-of-pocket monthly costs compare to the cost of the Medigap premiums? And what costs do you need help paying for? Do you use a lot of medications with durable medical equipment that have a 20% coinsurance? Do you go to the doctor monthly, weekly? And are you owing out of pocket for every doctor's visit? If so, perhaps a Medigap policy would be beneficial because those 20% coinsurances really add up and would be less or would be more than the amount you're paying in a premium. And the Medigap policies are all lettered. The different letters refer to the different types of standard benefits they offer. And so when you're looking, something to keep in mind is that Plan A tends to cover fewer costs than other Medigap plans. So if you're looking for more comprehensive coverage, you maybe don't need to look at Plan A. Plans F and G are the most comprehensive. They cover the most costs. And plans C and D are very comparable. And so maybe F, G, C, and D are ones that you want to look at. Plans F and G also have a high deductible option where first you have to meet the deductible and then the Medigap plan starts to cover your costs. And the premiums for those tend to be lower. So if there's a year where you're not sure if maybe you're going to be using your Medigap a lot, perhaps the high deductible option is a good way to go because the premium is lower. And then if you do end up needing it, then it's there for you with the high deductible. Premiums also tend to be lower for plans K, L, and N, like Nancy. But with the lower premiums come, sort of caveats. Plans K and L only cover part of your Part B coinsurance until you reach an out-of-pocket maximum. And so I provide all of this just as a baseline. If Medigaps are something you're thinking about specifically, then you'd want to look in more detail at these sorts of considerations. All right, so those are the differences between original Medicare and Medicare Advantage at a high level. Which one is right for you really depends on the providers you see and your financial situation, how much you're able to or want to spend on your health insurance premiums. A second component of choosing Medicare coverage is thinking about the prescription drug benefit. And this is the outpatient prescription drug benefit for anyone with Medicare. You can get a Part D plan if you have, at a minimum, Part A or Part B. These plans are only available from private insurance companies and they charge a monthly premium. The average is around $35 to $40 per month, but there's of course a lot of national variation. If you have original Medicare, as I mentioned, original Medicare just has Part A and Part B. So with original Medicare, you purchase what's called a standalone prescription drug plan. And this is a private plan that only covers prescription drugs. It means that you'll have a card just for your drug benefit, and you'll give that to your pharmacist when you go to pick up your prescriptions. If you go with a Medicare Advantage plan, it combines all of your benefits under one plan. And so you don't need a separate drug plan. It's just included with the same coverage that provides your hospital and your doctor's benefits. So here again is that important word formulary. Regardless of how you decide to receive your Medicare drug coverage, whether through a standalone plan or your Medicare Advantage plan, each plan is going to have its own formulary or list of covered drugs. So looking for a plan that has your drugs on formulary is very important. Each plan, like with Medicare Advantage plans, there's a lot of variation. They charge different premiums, they have different deductibles and co-payments. In 2025, the average premium for a basic Part D plan is around $36, and the maximum deductible that a plan can charge is $590. That doesn't mean that every plan will charge that premium or that deductible, but that's the maximum they can charge if they have one. Part D plans also use tiers to categorize prescription drugs, and you pay less for drugs in lower tiers. But of course, the way the tiers are structured is the lower tiers are usually very common generics and preferred brand name drugs. As you go up in the tiers, the higher the level, usually the more specialty the drug and the more expensive it is. And so when looking at drug plans, you want to find ones that have your drugs on lower tiers. But sometimes if you take something like a specialty drug, it's almost always going to be in that higher tier, like 4 or 5, and it might be harder to find a plan that has it in a lower cost tier. So one really helpful tool that will provide information about all of the drug plans available in your area is the Medicare Plan Finder. You can go to medicare.gov and access it from the homepage, or go to this specific URL, medicare.gov/plan compare. You can put in your zip code and the drugs that you take, their dosages, how frequently you pick them up, and the Medicare plan and the pharmacies you use. And the Medicare Plan Finder will show you your estimated costs for the different plans. And it will have the cheaper plans at the top of the list and the more expensive plans as you go down the list. As you're looking for drug plans, especially during the open enrollment period, some questions to consider are: my needed drugs on the plan's formulary? This is where doing that custom search can be really helpful. Otherwise, you're calling plans up and asking them, or you're looking through the formularies for the plans yourself. Not maybe the most efficient use of time or the most fun. Prescription drug plans can also put coverage restrictions on your drugs. So they may say you have to get prior authorization, or there's step therapy for this drug. That means you have to try a cheaper version first. And if you've tried the cheaper version and it doesn't work for you, then that step therapy is another coverage restriction that you and your doctor are going to have to appeal and ask the plan to take that restriction away in your case. And so if you're able to find a plan that doesn't have restrictions on your drugs, it's not always possible, but it is the ideal, that will result in the fewest number of barriers to accessing your drugs. And then a quantity limit is kind of what it sounds like. It's when your plan says you can only get 30 of these pills each month. And so if you need 45, you have to appeal and ask the plan to make an exception and say, okay, we'll cover 45. So just things to be aware of. And when you are doing a plan search on medicare.gov and you put in your drugs, it will tell you if any of the drugs you take have restrictions for the plans you're looking at. As I mentioned, seeing what tier your drugs are on is also a way of knowing in advance if the drug is going to be expensive. Sometimes it's unavoidable. We have to take a drug on a higher tier. But if you take, a sort of common brand name drug, maybe the pharmaceutical company has a good relationship with one insurance company over another, and it's going to be cheaper and in a lower tier for one company versus a different company, and you're able to find a plan that will cover it at a lower cost. And then lastly, just like with Medicare Advantage plans having networks of providers, pharmacies also have networks, or Part D plans also have networks of pharmacies. And so Medicare.gov, when you do a custom search, it will also show you which pharmacies are in network or preferred by your plan. So not only do we have in-network pharmacies, within that category, there are preferred pharmacies. An in-network preferred pharmacy is going to have the best cost sharing, the lowest costs. A regular in-network pharmacy will still have low costs, just not as low as a preferred pharmacy. And so again, this is something to navigate. Doesn't matter which pharmacy you use, if you can use mail order or whichever pharmacy is in-network and preferred by your plan, then that's fine. But if there's one that you really like to use, you have a relationship with a pharmacist, they deliver your drugs for free, it's closest to your house and easiest to get to, you're going to want to make sure that your plan covers that pharmacy as an in-network preferred pharmacy. And I think something that is common just across everybody with Medicare, but especially people who have multiple health conditions, is prescription drug costs can be so expensive. So obviously the goal is to choose a plan that covers your drugs at the lowest cost. The simplest way to do that is making sure that your plan has all of your drugs on your formulary and has your pharmacies in network and preferred. So for example, if there is an inhaler, a specific inhaler that you take, you want to make sure that that's on the plan's formulary, because the out-of-pocket cost for that could be hundreds, thousands, it can be very expensive. Other options, it's not always possible, of course, to, especially if you have a large drug list, maybe find a plan that covers all of your drugs or has your pharmacies in network. The way that coverage is structured, doesn't necessarily work for all of us. And so other things to look at are whether or not you qualify for any cost assistance programs. So two main ones for prescription drug costs are Extra Help, which is a federal program administered by Social Security for people with limited incomes, around $1,900 a month for an individual and around $2,500 a month for a couple. It pays for some of your premium. It makes your co-payments around $5 for generics and around $12 for brand names. And then some states also have what are called state pharmaceutical assistance programs, or SPAPs. And the best way to learn if you're eligible for these programs is, again, to contact your state health insurance assistance program. SHIP counselors work in every state. They'll know if your state has an SPAP. They can help you apply for Extra Help on Social Security's website if you can't do it yourself or you would like assistance. They're a great resource. And then there are also online resources that you can use. And these are not health insurance programs, and they're not alternatives to health insurance. Needy Meds and GoodRx can help you find coupons or manufacturer discounts for prescription drugs. And then Cost Plus Drugs, Mark Cuban's website, where he helps connect people with lower cost prescription drugs, just paying out of pocket. I think he takes the middleman out of things. And again, they are not alternatives to a Part D plan, but if you're finding that you just can't access your drug through the traditional means, checking out some of these resources can be a good resource. Checking out these resources can be a good option. Another good thing to keep in mind is that there are some pretty major changes happening with Part D coverage in 2025 that will hopefully have a positive impact on your out-of-pocket costs. So the first is, starting next year, there's going to be a $2,000 cap on your out-of-pocket prescription drug costs. This includes your deductible. So if your plan has a $500 deductible, your cap is not $2,500. Your cap is still $2,000, and that $500 gets counted towards the $2,000. And the $2,000 is also met by what you pay for copays and coinsurance. Once you meet that $2,000 out-of-pocket limit, you pay $0 for your covered prescriptions for the rest of the year. So this, not everyone's going to hit $2,000, if someone just takes one blood pressure medication, but for people who have multiple prescriptions, specialty prescriptions that are covered by their plans, but still have really high copayments, that $2,000 is going to protect you from having further costs beyond that. Additionally, and especially relevant to people who will meet that out-of-pocket cap early in the year, you're going to have the option to spread out your costs over the course of the year. So instead of, if you take expensive medications and right off the bat in January, you owe $2,000, instead of having to cough up all of that money right away, you're going to be able to sign up for the prescription payment plans that you're billed monthly for those prices rather than owing it all at the beginning of the year. This is called a Medicare Prescription Payment Plan, or MP3, or MPPP. The acronym is, a little funny, but it's basically a payment plan that all Part D plans must offer in 2025. You can sign up this year during the open enrollment period that starts October 15th. So if you had expensive drug costs this year and you will next year as well, your plan has likely reached out to you, or you may have gotten information about this at the pharmacy that you can sign up for this drug payment plan. If you sign up, your Part D plan sends you a monthly bill for your cost sharing. So when you go to the pharmacy, you pay $0, and then you get a bill in the mail from your plan for what you owe. And basically, it looks at what you would have owed in the month that you're going to the pharmacy, any balance you have from the previous month, divided by the number of months left in the year. So it's most beneficial to people with high out-of-pocket drug costs to sign up earlier in the year when there are more months over which those payments can be spread. And one common misconception is that this is like changing your drug costs or lowering them. It unfortunately doesn't change what you owe during the year. It just spreads it out and helps you manage monthly expenses rather than spending a higher amount in the beginning of the year. You spend a little bit every month instead. And this is something, again, that you opt into through your Part D plan. And the notices that you start receiving from your plan about changes for 2025 should include information about how this option is now going to be available. So now that we have a sense of the Medicare coverage landscape, we have traditional Medicare through the federal government, no network of providers, but no out-of-pocket cap. So usually need a Medigap, Medicare Advantage, private plans that offer Medicare, have networks of providers, might have coverage restrictions, offer coverage for additional benefits. We are going to talk about Medicare coverage for common COPD treatments. And the structure that we'll be using is we're going to talk about how original Medicare covers these services, because Medicare Advantage plans must cover what original Medicare does, but they can just have different costs or restrictions. And so they can't, original Medicare covers durable medical equipment under Medicare Part B. A Medicare Advantage plan can't say, oh, we're not going to cover durable medical equipment. They have to cover it as well. And durable medical equipment, or DME, is covered under the outpatient part of Medicare, so it has a 20% coinsurance. It is equipment that serves a medical purpose, is able to withstand repeated use, and is suitable for use in the home. And on the next couple of slides, we're going to talk about common DME for people with COPD, including oxygen equipment, CPAP therapy devices, and nebulizers. But before we do, the overarching thing to keep in mind in this next section as we talk about coverage rules is that before anything, there are two kind of main things that have to happen. So in order for Medicare, be that original Medicare or Medicare Advantage plan, in order for Medicare to cover your durable medical equipment of any kind, generally, you need a prescription from your doctor and for your doctor to document in your medical record that you meet the coverage criteria. So for different types of equipment, there are different requirements you have to meet, and your doctor has to document that so that Medicare and the supplier and everyone involved knows that according to Medicare's requirements, you qualify for coverage. And the second important thing is to use either a Medicare approved supplier with original Medicare, and you can find Medicare approved suppliers on medicare.gov, or a supplier who is in network for your Medicare Advantage plan. And you can call your plan or use their online provider directory to find an in-network supplier. Unfortunately, not every supplier is going to work with Medicare or be in network for your plan. And so, if the pharmacy around the corner, if they say, oh, we have the diabetes equipment that you need, or we sell walkers, that's not always necessarily going to be covered by Medicare if that pharmacy is not a Medicare approved pharmacy, supplier, or in network for your Medicare Advantage plan. So the first step is always to make sure you're using the right type of supplier. Specifically for oxygen equipment, which we'll talk about first, there are three main coverage criteria that your doctor should know about and be able to help document in your medical record. So First, you have to have been diagnosed with a severe lung disease that can be treated with oxygen therapy. You have to have a blood test to make sure that your blood gas levels meet specific criteria and testing requirements. And the third requirement is that all other treatments have failed or are not effective. And again, for oxygen equipment, your doctor in your prescription in the written order for this equipment will be required to document all of this to show that you need this equipment and you qualify for coverage. So with oxygen equipment, the way the coverage is structured under Medicare is that it's rented in a 5-year cycle, and you don't have the option to buy it outright and own the equipment. For the first 36 months, your supplier is paid by Medicare the monthly rental fee. And after the 36-month rental period, there are no more rental fees, but your supplier still owns the equipment. And so for the last 2 years, you have the coverage, but there's no more rental fee. And then at the end of 5 years, you can get new oxygen equipment from your current supplier or switch suppliers if that's what you choose to do. And so the way that this 36-month and then 24-month breakdown within the 5 years impacts you is that for the first 36 months, you owe 20% of the rental fee. And that includes the equipment, the oxygen, and the supplies. And then if you need any maintenance on the equipment, there's no cost sharing. So here is, a situation where having a Medigap might be helpful. If you're owing this 20% of the rental fee every month, perhaps having a supplemental plan that pays for that is helpful. Or perhaps looking for a Medicare Advantage plan that has low co-payments for their durable medical equipment is something you want to look out for. In the last 24 months of that 5-year cycle, after the rental fees are done, you still owe a 20% coinsurance for oxygen each month, and then a 20% coinsurance for maintenance. So basically with this durable medical equipment, you're owing 20% of the cost of the services every month. And that's just something to keep in mind when looking at plans or Medigaps that might be right for you. The second type of durable medical equipment that I wanted to talk about are CPAP therapy devices and accessories. So with this, Medicare first covers a 3-month trial period if you've been diagnosed with obstructive sleep apnea and you meet certain requirements for the frequency of breathing disturbances that you experience at night during the day. And this, again, is something that your doctor would help document in your medical record to ensure you get coverage. After the trial period, so after 3 months, if you meet with your doctor and they document that the machine is helping you, then Medicare coverage continues. Medicare pays rental fees for the first 13 months. You owe a 20% coinsurance of that rental fee. And then after 13 months, you own the machine. And so what that means is, so for the first 13 months, when Medicare is paying the rental fee, you owe 20% of that rental fee, and there's no cost sharing for repairs and maintenance. After the rental period, no more rental fee. So you own that equipment, you don't have a monthly cost that you're paying. But if you need repairs and maintenance or supplies, you're owing the 20% coinsurance of the maintenance and you're paying for the supplies out of pocket. The third type of durable medical equipment is nebulizers, and they're also covered by Medicare Part B. It covers the nebulizer as durable medical equipment, and then any medications you use with that durable medical equipment are also covered under Part B, like BOY. And so any cost for the medications would be If you have original Medicare with a supplement, the supplement would pay for the cost of the medications. Or if you have a Medicare Advantage plan, you'd want to check with your plan how much they're going to charge for that. Similarly to the CPAP machine, Medicare pays the rental fees for the first 13 months, and after 13 months, you own the machine. And so the cost sharing kind of follows. You owe 20% of the rental fee in that first 13 months. You owe a coinsurance for the medications, and then there's no cost sharing for repairs and maintenance. After the rental period, you own the machine. So there's no more rental fee, but you still owe out of pocket for the medications and for repairs and maintenance. There's a slight difference between nebulizers and inhalers, especially when it comes to coverage. With inhalers, these are going to be covered by Medicare Part D. And you're going to want to make sure that the inhaler you use is on your plan's formulary. So the cost can vary depending on your plan and the pharmacy you use, as we discussed earlier. And then the last service specific to COPD that I wanted to talk about are pulmonary rehab services. They are covered if your doctor gives you a referral and you have moderate to severe COPD, or if you had COVID-19 and have symptoms that don't go away for at least 4 weeks. And this is again covered under Part B with a 20% coinsurance if you have original Medicare. If you have a Medicare Advantage plan, you should check with your plan to see how much they charge for these services. All right, so we have 2 more sections I will go quickly through. I think in general, but especially for people who take a lot of medications or have multiple health conditions, navigating Medicare coverage and making sure everything gets covered can be really a lot to handle. And so I just in this section wanted to provide some tips and things that you might want to look out for. The first is that when you go to the pharmacy, it's possible that you might learn that your plan will not cover your drug. Your pharmacist will give you a notice in general about your appeal rights. And what you want to do is contact your plan directly to learn why it's not covering your drug. Some common reasons for non-coverage is it's not on the plan's formulary, or your plan has step therapy. It wants you to try a different, less expensive drug first, or your drug is excluded, or you need to request prior approval. These are all reasons why your drug may not be covered. In all of these cases, except that your drug is excluded, you should probably appeal and ask your plan to make an exception to its rules. The first thing you'll want to do is speak with your doctor once you know why the drug is not covered. And if your doctor says you can't switch drugs, you need to take the brand name, you can't take the generic, step therapy won't work for you, you'll want to file an exception request. You can ask your plan how to file this and ask your doctor for help. It's really important to include your provider because the exception request that you file should include specific information about why you need the drug covered and why alternatives won't work for you. And that's information that your provider can give you and that your provider can provide much more easily than you can. So you should ask your doctor for an exception request letter that explains why the medication is necessary, why other alternatives on the formulary have been ineffective, and call them out specifically by name, or that based on the doctor's knowledge of your situation, all other drug or dosage alternatives are likely to be ineffective or cause harm. In addition to drug denials, you may also encounter prior authorization. And this, as I mentioned, is when your plan requires you to ask for permission before it provides coverage. It's usually found in Medicare Advantage and Part D plans, but original Medicare may require it for a couple of limited services. With prior authorization, the first thing, ideally you would know in advance whether or not your plan requires prior authorization. And it usually comes into play for expensive services like hospital stays and chemotherapy. And before you get those services, your doctor needs to contact the plan and ask for prior auth. If you do not get your prior authorization request approved when required, your plan will not cover your drug, service, or item. And then this can cause, a whole cascade of issues. You owe higher out-of-pocket costs, you need to appeal. So when possible, know whether or not your plan has a prior authorization requirement and try and get that approved in advance. And a last sort of advocacy tip is that if things are not going as planned, which they might, know that you can file a complaint or grievance. So if your Medicare Advantage plan is giving you the runaround, they're not responding to your prior authorization request, they are giving you weird information and conflicting information whenever you call, you can file a complaint against them or against your Part D plan by calling 1-800-MEDICARE or by filing a grievance with your plan. Similarly, if your durable medical equipment supplier is, they deliver broken equipment, or they deliver things not on time, or they set something up wrong, you can call 1-800-MEDICARE to file a complaint against the supplier, and you can also submit a complaint with the supplier. And so keeping these ideas in your back pocket for when things go wrong can be a way, especially complaining to Medicare, they have oversight of these plans, of these suppliers, they can put pressure on them to do what's right by the consumer. All right, and then lastly, I've mentioned follow-up and enrollment a couple of times during this presentation, and so just to put it in writing, all of these things, how does Medicare coverage between original Medicare and Medicare Advantage differ? How does Medicare cover services and prescriptions related to COPD? Come into play for follow-up and enrollment because between October 15th and December 7th of this year, you can change your coverage for next year. If you find that your coverage is no longer going to have your doctors in network, or your drugs on the formulary, or the co-payments are going up. The really important thing to do is to review your current coverage. And if you're dissatisfied with your coverage for next year, you can make changes during this period between drug plans, between Medicare Advantage plans, and so forth. So if you have original Medicare, not much really changes from year to year, but you probably received your Medicare New Handbook. Any changes will be noted with little icons in the sidebar. You can skim through that to see what might be changing for 2025. The main things being, of course, the $2,000 cap and the payment plan. If you have a Medicare Advantage or Part D plan, you should have received already by September 30th your annual notice of change or your evidence of coverage. These notices talk about the changes in covered services and costs and covered drugs for next year. They might have been sent through your email, or it might have gotten lost in the mail. So if you didn't get it, you can contact your plan to have a new one sent to you. And then once you've decided, if you do want to change coverage for next year, we recommend calling 1-800-MEDICARE to make those changes rather than going through some online portal or something like that, just because there's more of a paper trail. But you can also call a plan directly to enroll. Just be very clear about the name of the plan that you're enrolling in so that nothing gets messed up. And then lastly, I'll leave this here as we go through the questions. The Medicare Rights Center, our helpline, is open from 9 a.m. to 3 p.m. Eastern, Monday through Friday, for any and all of your Medicare questions. If any were, prompted by this presentation that are very specific, definitely recommend calling our helpline. Oh, you're muted.
Sorry, absolutely. Thank you so much, Emily. So we do have a good amount of questions, mostly centered around Part D coverage and our Part B DME coverage. So let's get started on those. Sorry, how does our Medicare coverage differ for specialty pharmacy medications? And what steps would you take to make sure that those treatments are covered? I think you covered that a little bit, but I'll let you go a little bit more in depth into that.
Yeah, definitely. So yeah, with any pharmacy, you're going to want to make sure that it's in network for your plan, for your drug plan or your Medicare Advantage plan. And that sounds very vague because it kind of is. The best way to learn if your plan is in network is, as I mentioned, you can use the Medicare.gov plan finder. You can log into your account, or you can just do a sort of general search for your zip code and the drugs you take. And the pharmacies you use, you can search for the name of your pharmacy specifically and then see if it's covered by your plan. Or you can call a plan directly and ask them if, regardless of what your plan tells you, we always recommend trying to get that in writing. So if they say, yes, this pharmacy is covered, it's a network, you're going to owe, low co-payments, say, great, can I have, the evidence of coverage, or can I have something in writing that says that?
Thank you. So there's a little bit of confusion on the Part D coverage. So the $2,000 prescription cap, does it happen before or after the deductible is met? And then there's a clarification question. Does that include specialty drugs in that $2,000 cap? And does that mean that the donut hole went away?
Yes, great questions. Yes, the donut hole went away. Up until now, yeah, and especially I'm sure everyone in the audience, if you take expensive drugs, you know that there's this like cliff in the middle of the year, or even, in the beginning of the year, you'd have to pay 25% of the cost of your drugs at some point. And especially for expensive drugs, 25% could still be hundreds of dollars, thousands of dollars. So the donut hole has gone away. You now, after $2,000 that you've spent out of pocket, have $0 for the rest of the year for your covered drugs. It does include the deductible. So if your plan has a $500 deductible, or I think $490 was the example in the question, that $490, whatever the deductible is, counts towards the $2,000. And yes, whatever you pay for covered drugs counts towards the $2,000. So if you take specialty drugs and they are on your plan's formulary, that cost will count towards the $2,000. And depending on how expensive that specialty drug is, one refill of that drug might have you hitting the $2,000 cap.
And so another question is, can drug plans change their formulary at any time? So the Find a Doc tool is only for doctors who take original Medicare. Can the network Medicare Advantage plans take all of those same doctors as well?
Yeah, so first I'll talk about the formulary changes. Yes, plans can technically change their formularies mid-year. Usually that's if new information comes out that maybe a drug is no longer safe or something like that. The plan would take that off the formulary. But sometimes, yeah, there are mid-year changes to just kind of standard drugs, and plans are unfortunately allowed to do that. If it's a significant change, you can change your plan, but otherwise, they're supposed to provide you with sort of like a transition fill to help you get that coverage now that the drug's no longer covered. With regards to looking up providers, yes. So on Medicare.gov, you can look up providers who take original Medicare. And those providers may also be in network for a Medicare Advantage plan. It's likely they take at least some Medicare Advantage plans. They may not take all. So if there's a provider that you want to see and you are interested in a Medicare Advantage plan, one good thing to do is ask that doctor, hey, which plans do you take? And they might tell you, oh, you take the United Healthcare plan and the Humana plan, and then you can kind of narrow down your choices from there.
And do all providers take Medicare, or and can you explain like that co-insurance for like office visits and stuff?
Mm-hmm. Yeah, so I would say, I think the stats are pretty much 99% of providers take Medicare in some way. The types of providers least likely to take Medicare are mental health care providers, psychiatrists, psychologists, due to sort of historically lower reimbursement rates. It can be harder to find providers who take mental health care providers who take Medicare, but it is improving slowly but surely. But yeah, so most, hospitals are going to take Medicare. Medicare is a huge source of funding for, or, income for these large facilities. So they're all going to take Medicare. Whether or not they're in network for your plan is another story. There's more variation there. But if you have original Medicare, you have a lot of flexibility in the providers you can see and get coverage. The 20% coinsurance for an office visit with original Medicare would be you pay 20% of whatever Medicare says that visit costs. And there are regional differences. And so it's hard to say, what a doctor's office visit might cost. You can look up price estimates on Medicare.gov. You can ask your provider on average what you might expect to owe as somebody who has original Medicare. And if you have a supplemental plan, that kind of guesswork is taken out of things a little bit because the supplemental plan pays for that 20%.
Minimizes that,
Yeah.
that cost for you a little bit. Yeah. So can people start to look up plans now, or do they have to wait until that open enrollment period happens?
Yeah, so the 2025 plans are available online now. If you go to medicare.gov on the homepage, it says something like find, compare plans now. And if you click on it and you do a search with your zip code, it defaults to the plans for next year. So those are already available. You just can't make any enrollment choices until the 15th.
So coming up, right?
Coming up, yeah, it's soon.
Yeah, absolutely. Back to our Part D question. Does Medicare pay for a medication after a transplant, for example, a lung transplant, kidney transplant, so on and so forth? Could that go toward our Part D coverage?
Yes. How Medicare pays for immunosuppressants after was it immunosuppressants? Let's see.
It was
just medication
after a transplant. Yeah.
Sorry, I assumed it was immunosuppressants. I'll talk specifically about immunosuppressants and then just drugs in general. For immunosuppressants, Medicare covers them under Part B like boy if you had Medicare. Part A cover your transplant. So if you were already in Medicare and you get your kidney transplant or your lung transplant, Medicare Part B like boy pays for your immunosuppressants. And so that means that they have a 20% coinsurance, and having a supplemental plan would, help minimize that cost. If you didn't have Medicare at the time of your transplant, maybe you hadn't enrolled yet because you had coverage through work, or you weren't eligible for Medicare yet, and then you get on Medicare and you need immunosuppressants, then it's covered under Part D, like dog, the drug benefit, and those costs for the immunosuppressants would count towards the $2,000. And then just any other drugs in general that you might need after a transplant would also be covered under Part D and count towards the $2,000 cap.
Excellent. So I think we only have time for one last question. So I'm going to merge a couple of them into one.
Yeah.
So they're all kind of similar. Medicare pays for CPAP and BiPAP, portable oxygen, traveling tanks, with a 20% coinsurance, correct? Could you explain that a little bit?
Yes. So I know using the word coverage is kind of confusing because when I say coverage, I wish it was like this, but it's not. Coverage doesn't mean that you have $0 of costs. Medicare covering CPAP machines or oxygen equipment means that usually it's paying 80% of the cost of this rental fee or 80% of the cost of the supplies, and then you pay 20% in addition to the 80% that Medicare paid, which then equals 100% payment to that supplier. And specifically with portable oxygen equipment, I just wanted to specify, because this does come up, Medicare's coverage rules are maybe a little bit behind the times. And with durable medical equipment, they really are focused on equipment that's used in the home. And so with a portable oxygen, If the main reason why you need it is to go outside the home, Medicare is not going to cover it. But if you are mainly still going to be using the portable oxygen in your home, maybe the regular concentrator is like too heavy or something like that, then Medicare will cover it. But that is, yeah, just a sort of frustrating barrier to cover sometimes is if your doctor's like, oh yeah, it'd be great if you could, leave the home with these supplies. Medicare might say, oh, but we want it to be mainly home for home use. And so that's something to discuss with your doctor, whether your specific need for the medical equipment would meet Medicare's coverage rules.
Absolutely. Thank you so much, Emily. So, everyone, thank you for joining us today for the COPD and Medicare Made Simple, preparing for the annual enrollment period. We hope that this presentation helped guide you on your selections during this annual enrollment period and answered any questions that you had about your insurance coverage. A very special thank you to Emily for joining us today and walking us through these coverage options. If you guys have any specific questions about what coverage is best for you, I encourage you to call the Medicare Rights Center. They would be able to have a more personalized touch based on your information on where you live and and your personal situation. If you would like more information about COPD and other chronic lung conditions, please visit the COPD Foundation website at www.copdfoundation.org. Take action today, breathe better tomorrow. Have a great rest of your day, guys. I hope you have a wonderful day. Take care.
Thank you.